postprandial, we now discuss major depression. I'm sure you're all aware this year alone in March, the FDA approved brexanolone and also Esketamine, so GABA and glutamate targeting drugs. So we actually had some very novel treatments in depression in the last year. Nothing's changed since this morning, I suspect, in terms of disclosures. You never know, these things can be fluid. Okay, let's get underway. A couple of, and again, I'll do the same way and as this morning and Christoph's, just sort of kind of rounding the bases a little bit, just what's new, amplifying what we are, topics that we've discussed before, and what have you. So this is in fact part of a real paradigm shift that's occurring in depression towards patient-reported outcomes. I thought you might find it interesting that DBSA's meeting with the FDA in November for the second of two meetings wherein the FDA has begun the discussion with various stakeholders with an aim to determine whether future antidepressant approvals should be approved on the basis of PROs, patient-reported outcomes, rather than the conventional HAM-D17 or the MADRS. And for those who are wondering, well, why would we do that? What's the impetus that would be driving this? Many studies like this in the field that have come from many groups. If you take adults with depression who are in remission, this is the MacArthur definition, 7 or less on the 17, about half of these individuals, when asked about their current state, would not describe themselves as well. Half of people in remission, according to a clinician metric, do not describe themselves as well. And again, that's been replicated, that's been looked at from many different perspectives, and this conflates many aspects of quality of life and function and positive well-being. I thought you would find that interesting. There was a product actually that was reviewed this year by the FDA but rejected. It was a combination of buprenorphine and samidorphan. It was going to be the first antidepressant that was opioid-based, and it was also an antidepressant that was planning on, in fact, looking for a separate anhedonia indication. But there was a longer story to why that one was rejected. It wasn't the concept, it was a trial design issue. But my message is on the patient-reported outcomes, and as we're tracking what are the outcomes that matter most, how should we be involved in measurement, what type of measurement, that's something to keep in mind. Now, this is another area that's really been amplified again the last couple of years with the emphasis on PROs, patient-reported outcomes. This was STAR-D, this was mediational analysis, looking at which items, in this case of the QIDS, account for more the variance in function in depression. So the preface would be all symptoms of depression are not created equal. The second one is that cross-sectionally, there's a very, at best, modest to low correlation between depressive symptom severity and patient function. And when we get into the weeds of this, there are some symptoms or some items that are accounting for more impairment in function than are others. And this is really part of a broader interest in domain-based psychopathology. Lots of items here, but when you analyze this, these factor out as cognitive items and reward items. And I'll do the math for you. About 2/3 of the impairment in depression is a result of impairment in general cognition or reward. And this has been shown many times that in epidemiology as well as in clinical studies, the total depression symptoms severity score accounts for very little of the standardized beta, the degree to which, in fact, in this case, workplace impairment is attendance and performance is accounted for by total depression symptom severity is very low relative to measures of cognition. Again, that has implications conceptually, but to keep this to the point of today's exercise, thinking about measurement and what are therapeutic objectives. I call this the LDL cholesterol slide. If this was heart disease, the correlation with total cholesterol may not be as interesting as it is with LDL cholesterol. So we're getting into more of this so-called fractionation of symptomatology in the area. The other area, just again, this is something to keep in mind. Anhedonia, again, the academic point, we know this is a core disturbance in depression. On the DSM-5 list, it's one of those requisite items if you don't have a disturbance in mood. And this area is really interesting academically and clinically. Anhedonia really is a conflation of anticipatory as well as consummatory pleasure. And there has in fact been a notion for a long time that dopamine is your pleasure neurochemistry, but in actual fact that's partially true. It's mostly involved in anticipation. It actually plays next to no role in consummatory pleasure. That's largely driven by opioid and cannabinoidnergic mechanisms. And in our patients we see with depression, they often have disturbances in both areas. But some actually have more of an impairment one than the other. And in animal models now of depression, there's increasingly the view that the real difficulty is not so much in the consummatory phase at all, but it's actually in the anticipatory phase. Now, when a patient walks into a clinic, they don't say, I've got anticipatory anhedonia. That's not usually what they have as a chief complaint on the referral letter. What they say is, I'm tired. They say is, I'm fatigued. I lack motivation. My life is missing joie de vivre. I'm apathetic. That's for you, Marie. That's
You can say that again.
yeah, missing joie de vivre. It's I'm apathetic. What the patient is really saying to their clinician is that the energy expenditure is not actually matching what I praise to be the anticipated reward. So I'm lying on the couch. I'm tired. And so there's a lot of interest in targeting this area. Parenthetically, ketamine has been particularly good at helping some of these aspects in some recent data that we have. A question that always comes up from clinicians is emotional blunting. SSRIs, emotional blunting, are often in the same sentence. What is emotional blunting? It's a bit like how long is a piece of string. It kind of depends how you're going to define it. But emotional blunting is thought to be a good thing and a bad thing. The good thing is that if in fact you're someone with depression, you tend to have cognitive emotional biases. Next sentence is you have cognitive emotional biases towards the negative. That is experienced as an exaggerated reaction to real or perceived stress or slight. And so to have emotional blunting in that context could be interpreted as a good thing. The patient's less negatively reactive. But they're also less positively reactive. So they have a constriction of affect. They have a constriction of affect, and that's generally seen as a bad thing. And I think that every clinician sees this in patients who are receiving particularly SSRIs. There's a new scale that's been developed for this, an Oxford scale of blunting. It's not quite called that, but that's what it's really measuring. And SSRIs disproportionately have this issue. And it probably overlaps to some extent with the dampening of reward that we see with benzodiazepines in this population. So why I bring it up is A, it's common. Clinicians are often struggling. The patient I have with depression, on their PHQ-9 score, they're endorsing some items that I can't tell if it's emotional blunting or if it's subsyndromal depression. Can you help me with that? This is a very often question put forward. Oh, this is just from a recent publication on this. Very common that half of patients, in fact, prescribed SSRIs have this. This was a study that was recently published. So this is a very, very common issue. Patients have minimal reactivity to even normal experiences, weepy during a drama movie or what have you. But this is actually something that patients react with a lot of concern because they feel as though they're losing their control over their emotional state. This was published in August of this year. I reacted with incredulity when I saw this. This is looking at adults who've been given a diagnosis of major depressive disorder, and then that was then matched to what were they prescribed. And about, you can see, you can round this off, 10% of adults with MDD are prescribed benzodiazepine monotherapy. That was the punchline, and obviously that raises a host of concerns with respect to, again, this question about taketh away, and often that is an example of addition by subtraction, and then the giveth of what they should be on. To keep going with that, this came out a couple of months earlier, this paper, looking at benzodiazepine prescriptions, and I thought it was appropriate for today's meeting because this is largely in primary care. And in the last 15 years, there's been an upward trajectory of benzodiazepines in the US. Secondly, a significant uptick in the short-acting benzos, E.G. alprazolam. And thirdly, and it won't surprise you, there's been a quadrupling of co-prescription with opioids. So already thinking about our CCIs, the discussion for later. Now this is not synonymous with depression, but this is overlapping with depression. So we have lots of benzo monotherapy being prescribed as the treatment for our adults with depression, and there's this upward trajectory, so very concerning. By the way, no one's unaware that benzodiazepines are anti-cognitive. That's not unknown to anybody. Benzodiazepines also dampen reward, and that blunting and or anhedonic effect is often worsened by benzodiazepines in this group. Now, probably the anxiolytic that's being taken by patients most commonly nowadays is cannabis. And I bring this up, I think, first of all, we can discuss this. Given how common cannabis is, and you all know that in some states, younger adults are smoking cannabis more than nicotine and tobacco. I often make the case that, we often talk about smoking status. Often these product inserts say, no dosage adjustments required as a function of smoking status. That's tacitly implied tobacco. But a lot of patients are not smoking tobacco, they're smoking weed more often. And I don't think it's generally well known that that's a potent CYP3A4 inhibitor, 2D6 inhibitor. And there's questions about drug-drug interactions. Now, to stay with the evidence, what evidence do we have that CBD or THC9 are resulting in clinically relevant pharmacokinetic interactions, DDIs, with psychotropic drugs? And well, you're not going to be surprised to hear this, given the legislation of the last 20, 30, 40 years, that we don't have a lot of evidence, but we do have some. And it's something now that, is people are beginning to look at, because, about a third of our medications directly or indirectly affect CYP3A4 or rely on CYP3A4. So I thought that was just something for your interest. Okay, let's talk about genomics. This is really, I think, confused a lot of people. Pharmacogenomics, and this is just a snippet of some of the proprietary tools that are out there. The branding, I think most people know GeneSight. That's been very, very out there, marketing and so on. But there's many of these products out there. There's a few, and a number not on this slide. And just so we're clear, you have single gene genetics, and you have multi-gene genomics, pharmacogenomics, and the promise with these devices is that they could improve health outcomes and or cost effectiveness in depression. And you can just see from this almost death by all these initials and letters that they really are largely looking at allelic variants of kinetics. This came out on November the 1st. this is a chorus, if you will, with the American Psychiatric Association's position, as well as the Centers for Disease Control in Centers Prevention's position, that there still is in fact not a compelling body of evidence, that the use of pharmacogenomic testing reliably, robustly, reproducibly improves health outcomes in depression. And that comes as a bit of a surprise to a lot of people, because this seems to have been a behavior that's caught on far, far ahead of what the data support. So,
like the new pharma, right? They're out detailing.
Yeah, they are. Yeah, they are. It's aggressively marketed.
Yes.
Is there a risk of practitioners not using medications that could be beneficial or effective because of?
That was exactly, Scott Gottlieb was the head of the FDA when this came out, and that was exactly what he put in. This is just the truncated quotation, obviously, but part of that quotation is just that there's the real risk that there would be the denial of medication to a patient based on this so-called red bin, when the patient could have benefited from it. I have found that this is something that is very susceptible to expectancy bias and confirmation bias. People expect it's going to work. I'm getting real medicine. This isn't just Hail Marys, therapeutic Hail Marys. My clinician is a real clinician. I'm doing real science. I get this blood test done, and I'm in the green bin. It must work. That's your expectancy bias. But what I hear a lot of is the confirmation bias, where people will say, well, shame on you for saying that the FDA doesn't think it works. What the hell do they know? I've done it in 3 of my patients, and all 3 got better. That's called a confirmation bias, okay? That doesn't prove anything, okay? So anyways, this is because you all know these are directly marketed to antidepressants. And I was at a clinic in outside St. Louis, and big clinic, big volume, and they will not see any adult with depression unless they get the gene test done. Almost like you cannot see your orthopod without the x-rays. And I thought, my goodness, my goodness. Anyways, it's a big issue. Okay, let's talk about efficacy of antidepressants. This was the biggest network analysis ever done last year, published Lancet. Over 500 studies, over 100,000 participants, 21 antidepressants. The punchline almost was a bit cringeworthy. The punchline was antidepressants work. I thought, my goodness, thank God. That seemed, and people were celebrating. That was the punchline. I thought, oh, isn't that kind of a bizarre punchline? Anyways, they work. We have many, many different antidepressants. Clearly, a lot of these are not available in the United States. Differences in terms of acceptability, that is tolerability and safety. Which one's the most effective, we don't know. The studies aren't designed that way. There clearly are differences with respect to some of the dimensional outcomes, like the SNRIs in pain. Some of these agents have additional indications in the anxiety disorders. And then you have, within this orbit, you got vortioxetine, which has the FDA now allows the company to promote it in cognition. So you have some of these differences. But in undifferentiated depression, it's hard to differentiate the antidepressants. This is something, again, this was something we looked at in a very large database, just published this recently. And I think the relevance of this to today's exercise is how important it is to initiate the antidepressant soon after that diagnosis is made. What we found is that we looked at after the diagnosis of major depression was entered in, we had over 50,000 in this database of depressed adults. Once the diagnosis of depression is made, how long did it take to initiate antidepressant? And then how long did it take to achieve the minimum therapeutic dose? And what I would like to have seen is that this would be 100%, that would be 100%. In other words, they start right away, they target quickly. We still have people going very ginger on antidepressants. In other words, taking forever to get to a optimized dose. And I think depending on when you graduated, many folks would have graduated, I got a slide on this, hang on, yeah, right here, would have graduated and were taught that you don't tweak the doses for at least 6 to 8 weeks. And that's no longer the teaching. This was, actually this is probably the better slide. This is in fact the trajectory of response over time. And you can see what I can see, that even if you're on placebo, it's the same thing, but on antidepressants, you really start plateauing after 4 weeks. And there's been many studies now looking at improvement or lack thereof at 2 weeks, and to what extent does that have predictive value at 8 or 12 weeks. Conclusion, you know within 2 to 3 weeks whether the dose that you have started your patient on is the right dose. If you're not getting at least a 20% or greater improvement after 2 to 3 weeks, that is the call to increase the dose. And that's a seismic shift to what we were teaching not that long ago. Okay, now with respect to next step strategy, we're going to talk about second, third, and fourth line strategies and so on. But to put this in context, I call this the 15% rule. So if you've had, this is from STAR-D, 2 swings at the bat with about a 30%, 35% chance of remission, first swing of the bat, a 30-35% chance, second swing at the bat, 2 strikeouts. The next one, in fact, is only 10 to 15%. So it really speaks to how important it is to optimize and do it as efficiently as possible, integrating care for patients with depression. Now, this is in fact looking at the remission response rates for atypicals. We have to add brexpiprazole to this now. It's also been FDA approved to this. And they clearly have, they meaning this class, aripiprazole, quetiapine, brexpiprazole, they have the largest and most rigorous body of evidence supported by their respective sponsors as add-on treatments in depression. I have a slide, a separate slide, which I didn't put in this deck, which looks at what do people usually do. What people usually do is add an antidepressant, like bupropion, to an SSRI or SNRI or vortioxetine. And there's a real gap, it's a yawning gap between what the evidence says, what the FDA's approved, and what clinicians actually do. And what I hear from clinicians is 2 things. One, they're of the view that it's better tolerated to add bupropion. And secondly, often cost issues come into the play here. We're not going to get too much into this because I think Christoph covered many of the adverse events and so on. But this is a major problem in the adult with major depressive disorder in terms of the concerns around obviously EPS, short-term, long-term, sedation, particularly with quetiapine, the risk of metabolics and weight gain, and that's obviously an issue that comes up. And this has in fact been raised over and over and over again. These are major pushbacks against using these medications, atypicals, and I suspect this is why we're seeing a disconnect or this implementation gap between what the evidence says and really, in fact, what people are actually doing. But the evidence does support atypicals as first-line add-on strategies. This was a study called the VET. Yeah.
Is that dose-related?
Clearly is. Absolutely is dose-related. And as a guiding principle, the mean modal dose of atypical that's effective in depression is lower than you would prescribe in bipolar disorder, depression or mania, and certainly schizophrenia. But yes, it is definitely dose-related, perhaps with the exception of weight gain, but yes, it is, generally speaking. Yep. Now, this was a very interesting study. This was the VAST-D study, relevant because it mirrors clinical practice. These were persons, this was a VA study, Adults with MDD treated with antidepressant unsuccessfully. Well, what was done was they were switched to something different. They were augmented with bupropion or augmented with aripiprazole. And if I could convince you, the lines, I took this right from the article, aripiprazole has a slight win here. I mean, it's not a huge win, but just take my word for it, there is a slight win in favor of aripiprazole over switching and over bupropion, but aripiprazole had more side effects. And so this fork in the road, if I'm going to add something on, do I add the atypical FDA approved or do I add the antidepressant? I would respond by saying you should go with the best evidence and with what FDA is approved first. And there's no doubt aripiprazole has more evidence. But we're reminded there's a side effect issue, but to your point, it's dose dependent. So maybe in fact we can obviate that risk by using a lower dose. New entry, or what's going to find itself different in our guidelines this year is ketamine, specifically esketamine. And there's a number of new products that are still in development, and I'm just going to be really speaking to esketamine, which was the first of the ketamine moieties. There's another product that was progressing but ended called Rapastanil, and then just this year, also in March, Brexanolone was approved. So this is where there's going to be, I think, implementation gaps around the country. I hear a lot of clinicians telling me that they're giving their patients with depression oral ketamine. We'll say a few words about that in a moment. This is the bioavailability. I don't think this surprises you that the oral is less than the intranasal. And by the way, this is on a good day, about 50%. It's usually between 20 and 50%. And then the IV is the highest. I'm bringing this up because I have noticed across the country many people taking oral ketamine, despite the fact oral ketamine has somewhat underwhelming evidence of efficacy right now. The Johnson & Johnson product that was approved, Spravato's intranasal, and there's a plethora of these IV, usually racemic ketamine clinics across the state and the country. And by the way, I think everyone knows this has been around since the early 60s. It's marketed as a NMDA antagonist, but it has at least a dozen proximate and distal targets. There's no question that it's not just NMDA. With respect to treatment-resistant depression, this is the racemic ketamine. The racemic ketamine odds ratios in patients who have failed at least 2, often 3 to 5 antidepressants, and in many cases neurostimulation, odds ratios, response, and remission. We've seen nothing like this in 20 years. It's been pretty impressive. For those who are wondering, and this is the million-dollar question, what's the sustaining of this benefit? How is it sustained? There is, in fact, a quick decay of this, and it does appear as though a sizable, probably the majority of people, require ongoing continuation and maintenance. I don't have the slide here for today. We just finished a meta-analysis comparing the intravenous to the intranasal. We looked at intravenous racemic versus intranasal isomer, intravenous isomer versus intranasal racemic. Everybody could cut it. First of all, there's a lot of heterogeneity. That's a really important point. And a lot of these smaller, these original IV studies were done in fairly small samples. But not to get lost in all that. The point is that we could, it looks as though, based on the evidence, as imperfect as it is, the intravenous and the IN don't have a clear winner as to which one's better, just simply based on a MADRS reduction. The question about the speed of onset is really so critical here. And the benefit being detected within 1 to 2 days is obviously of huge importance in this population. The other question around suicidality, you know that suicidality integrates ideation, non-lethal self-harm, and completed suicide. It comes as a surprise to many people when they hear that the evidence does not suggest that they are contiguous. Those are actually orthogonal in many cases. In other words, suicidal ideation on its own has very, very little predictive value for completed suicide. That's a fact, and it kind of surprises people. And so, yes, we would like to see a reduction in suicidal ideation. Who wouldn't? And it looks as though that, in this case, this is Esketamine, is reducing ideation of suicide, so is the racemic, but we do not have any evidence yet that it actually reduces suicide. And so we welcome this, but I don't think that's really the thunder. We want to see reduction in suicide. I thought you'd find this interesting because this has been so much talked about now in the field. This was a very interesting concept where adults with depression, a small sample, less than 10, so just keep that in mind, were pre-treated with naltrexone. And then they were given placebo or ketamine. And it turns out that the adults who were pre-treated with the naltrexone, which is this orange or brown, or that is, they didn't respond as well to ketamine. And that was interesting in itself. And that was interpreted that, A, ketamine targets the opioid system, to be determined how it does that. Others said, well, no, it's not that. It's that you require an intact opiate system for this drug really to exert effect on NMDA. There's no question that even at the low doses of ketamine being prescribed, there is release of opioid in the animal models. It's debated whether you can actually engage mu opioid receptors at the doses that are actually given. Relevant to the patients with depression is this report that came out just a few months ago looking at ketamine combined with mindfulness-based treatment. Now, these are not adults with depression and cocaine dependence, although many of them did have that. The aim was to look at cocaine dependence. But this is, I think, is translational to many of the patients we see with mood disorders who do have substance use. And the punchline was it did have a benefit, actually, on cocaine dependence. Let's just say a few words, if we could, about the Esketamine studies, since this is a huge change. This is the first glutamatergic drug we have now for depression. There's 5 studies that were done, and these are short-term studies, and some are longer-term studies, and mostly in adults 18 to 65. There was an elderly study done as well. And this is, in fact, I should mention that the way these studies are done is that these are adults who have failed at least 2 antidepressants. So if you go back to that STAR-D finding, if you fail 2 antidepressants, your batting average is 10 to 15% remission after that. That's the benchmark. And then what happened is this was a very different type of trial design. They come into the study, meet the eligibility criteria. They're all started on a new antidepressant plus placebo, or new antidepressant plus esketamine. That's a very different way of designing a study. So usually what happens is that the augmentation drug, the atypical, is added to the inadequate drug, or placebo is added to the inadequate drug. In this case, the inadequate drug was stopped. And I'm bringing this up, I purposely don't want to get too much into methodology, but why this is relevant is people are asking, I have a patient who failed an SSRI times 2. Do I add brexpiprazole or do I give them esketamine? And it's a bit of apples and oranges to compare the way these studies were done. Anyways, there was a p-value that was significant, seen immediately in a day, and that was sustained out to the week 28 here with Spravato, esketamine added. Response rates are here. They're translating into single-digit NNTs around 6 and 7. And in treatment-resistant depression, particularly in that STAR-D framework, level 3 treatment-resistant depression, NNTs of single-digit NNTs are kind of unheard of. It's a very impressive finding that did sustain itself. Now, the proof is in the pudding when it comes to these treatments in terms of relapse prevention. So there was a relapse prevention done, and this is going to be relevant to how we guide people. Again, I'll stay away from the details, but they were stabilized, and they were categorized as either stable remitters, that is, their MADRS score was less than 12, or stable responders, and then they were randomly assigned to the antidepressant plus placebo, or 2 doses, 56 and 84 milligrams of esketamine. And this is the survival curve. So remember, these are folks who have been treated with esketamine plus antidepressant. They're either a stable remitter or a stable responder. And what I thought was interesting is that as soon as you take away that esketamine, look what happens. It's amazing. And what's interesting about this, just to kind of put a context on this, many of us wondered why this, if ketamine is so robust with odds ratios of 10 and those racemic, why is this between group difference not greater? And we wondered about, why is that? And one theory is that the reason why it's not greater is you get an inflated placebo response by starting a new antidepressant. But what's interesting about this is that that's not in keeping with that. It seems like as soon as you stop that esketamine, whoa, that's a pretty fast decay. So the next question people ask a lot now is how frequently and for how long? With respect to drugs in depression, we don't usually see this type of decay that fast in a relapse prevention design. But again, we have very few TRD studies that look at this question as to how long you keep people on the treatment for.
You also see a pretty steep decline on esketamine in addition. Right?
Yeah, you do. You do. You do.
Problem, no?
Yeah, you do. And yeah, you do. It is.
For response, it's much less.
Yeah. So between the groups, it's that you cut the risk in half. It seems like it's more interesting than the responders. But anyhow, yeah, you see this rapid decay in those who stop it, and you see a fairly concerning decay in those who are staying on it. Yeah. And so this brings up the question, was the dosing or the frequency, was it, I think many would know this drug's given twice a week for the first month, then every week for the next month, and then every week to 2 weeks thereafter. So maybe, to your point, Christoph, about long-acting, maybe it's too little. That's my sense. We at my center, we give IV racemic ketamine, and our experience has been is that most of these patients need the treatment weekly, and they need sometimes even twice a week during maintenance.
So how long do you go on with that project?
Well, the studies were designed out to a year. They've got data out to 1 year.
So every 2 weeks for a year you get an infusion?
Okay, so this is intranasal. This is intranasally delivered. And this was the sponsored studies by the company Janssen. They did them out to a year. With the IV ketamine, which is off-label, that's racemic ketamine, it's variable, depends on the actual individual, but we have some people coming every week, some come every Q2 weeks, some are coming twice a week. It just depends on the patient. But I don't think giving it every 1 to 2 weeks is sufficient for a lot of patients. Clearly it's not. Clearly it's not. The other thing too, not to get lost in this again, I'm trying to keep this very top line, is that we've been doing a lot of work with intranasal insulin. It's many different grants I have looking at giving non-diabetics insulin to enhance cognition. And we have found, this won't surprise you, that there's a lot of issues with the coordination. Just like people taking asthma puffers. It seems fairly simple just to coordinate the puffer. How difficult can it be to coordinate the intranasal spray? But I continue to be amazed at how wrong people keep getting this. There may be a coordination issue here as well. It's an issue. Anyway, this is the long term out to a year. The key thing I should emphasize is the safety here. People have been confused or concerned, about abuse, misuse, dependence, diversion, gateway. We don't have any evidence of that right now, and you guys all know there's a REMS in place for this product. And this is looking out to week 52. It's a single-digit NNT on remission out to week 52 with this product. So it looks as though this is going to be a long-term affair for many patients. This is one of the very few positive oral studies, and I suspect that's why it got into this publication. Most oral studies have not been positive and or have not exhibited the rapid response, but this was one that was positive. That's why I thought I'd make a slide of it. Oral ketamine. The challenge with oral ketamine, this is racemic, is the low bioavailability, and there's not really a lot of quality assurance, obviously, how these things are often being made at compound pharmacies and so on. Now the other one, I don't know if this will find itself, Marie, in the reproductive health, postpartum conversations, but so brexanolone was approved in March of this year for postpartum depression. And for those less familiar, this was developed in postpartum depression around a concept which is supported by some animal work and human studies that allopregnanolone, a neurosteroid level which is derived from, actually ultimately from cholesterol, but is decreased in the postpartum period. And by the way, neurosteroids are allostatic modulators of the GABA receptor, and GABA is the target of benzos, but benzos target GABA inside the synapse. These target GABA largely outside the synapse, and that's thought to reduce or mitigate the risk of depression symptom induction, anhedonia amplification, and anti-cognitive effects. And these were women postpartum, 60 hours of infusion, who demonstrate a significant improvement in depression, often within the 60-hour window, and then that was sustained out to a month. This is an IV delivery system. The company has a related molecule which is oral, but it's not yet approved. But the New England Journal published an article 6 weeks ago, which was their first oral. So this is going to be in an oral as well. Lots of questions about ecstasy and MDMA, psilocybin. We're doing a study at my center with psilocybin with a company in the UK. Not ready for prime time, that's the message, and should not be on our list of fourth-line treatments. That's the message. And I think it's important because there's people are now watching, the news, and they're hearing lots about how psilocybin works in depression. We don't know that. That's a testable hypothesis, and I certainly would not recommend this. Now, with respect to inflammation, big question keeps coming up. We have a conference next week in Colorado, or next week. We're going to have a lot of conversations about, should I give NSAIDs to my depressed patients? Should I give COX-2 inhibitors? And you guys have all been hearing about this. There's half of patients with depression are in a pro-inflammatory balance. There's been so many efforts to look at this. We just published a study using Remicade to treat bipolar depression, where it worked to some extent. But let me just walk this very quickly. I mentioned this morning about the biotics, pre-pro antibiotics. Of those three categories, the antibiotic minocycline, which, can I say, Christoph, in schizophrenia has been hit, miss, but more of a miss? Can I say it that way?
That's a big story.
Yeah, it's a real mix. Negative symptoms, cognition, I think we have to get the target right. This was, in depression, we're getting a signal. It's consistent that it's working as an antidepressant, but again, small studies, often single site, all that kind of thing. But again, I don't think we're ready yet to say that the anti-inflammatory, this is an antibiotic that behaves as an anti-inflammatory and also as probably a gut biotic manipulator. We don't think we're ready there yet. With respect to psychotherapy, a couple of comments about this. This is for adults who have TRD, treatment-resistant depression. It turns out that psychotherapy, this is important because a lot of people think if my patient doesn't benefit on a couple of antidepressants, aha, they must have a psychotherapy type depression. They need psychotherapy. Well, that's not true. It turns out that psychotherapy does not beat the treatment as usual in patients who failed a couple of antidepressants. So it feels right that they didn't benefit on a couple of SSRIs or whatever they got, so then they should go see a therapist. Well, that doesn't seem to be true. It seems to be the case that they do better when the psychotherapy is added to the antidepressant. So CBT, mindfulness should be added to the antidepressant and should not be as a monotherapy. So this is in fact this was a fantastic paper, missing the reference. It's in the World Journal of Psychiatry just a few months back. This is a slightly different network. Oh, here it is here. This is a slightly different a way of looking at it. The question in depression is no longer interesting. What's more effective, CBT or antidepressants? The answer is yes. The question really is are there features, are there aspects about the patient's depression that would guide me one way or the other? Now, there was a literature for a while that if the patient had multi-episode depression, persistent depression, depression in the context of trauma, the patient should be given manual-based CBT, and that should be reflected in the guidelines. And that's still out there, that thought that there are these characteristics of some patients with depression. What I thought was interesting about this and had tremendous face validity, huge analysis, concluded that antidepressants are actually more effective than psychotherapy if you have these, for these symptoms, which are largely mood and cognitive symptoms: depressed mood, guilty thoughts, suicidal thinking, tremendous rumination and anxiety. General symptoms is fatigue, and that's a motivational and cognitive symptom. And it shouldn't surprise anybody that if you're depressed and you're ruminating of guilt and suicidality, highly anxious and fatigued, that antidepressants would perform better than CBT, and it certainly did. So I think along with the history of trauma, history of multi-episode, as well as chronic depression, there are some target symptoms in depression or some features of depression that would guide you towards pharmacotherapy. And then final point.
So Roger, before you leave that, so are there on the other side then some indicators that would lead you to choose CBT over antidepressants?
Great question. In that study they did not find any. And I don't know the authors, I don't know what their political bias is, but they did not identify any factors predictive of superiority in the psychotherapeutic arm. Yeah.
Well, it's not very good for CBT that the guilty thinking, guilty thoughts went the other direction.
Yeah. You know how my interpretation of that is, and why I think that's got face validity, is that, and you know this, is that this is often a ruminative type feature. And rumination is a problem with executive function and attentional capacity. And you know, the impression I have had in these patients, because of the profound rumination, they just can't engage the psychotherapy. They have to have pharmacotherapy. That's a cognitive problem. And no different than the patient who can't, you know, has impaired memory and learning. They're not going to benefit as well from psychotherapy unless you can help them in that subdomain. So I see this as really more evidence that profound, and it seems counterintuitive, that people with the most profound cognitive problems may not be the best candidates for cognitive therapy. But Aaron Beck's cognition and this cognition are apples and oranges, right? Yeah. So
then would you think the same thing would pertain to using some sort of mindfulness intervention?
You know, I see psychotherapy philosophically as an opportunity for practice and plasticity. It's a relearning experience, and I think that just head on, I just think it's very difficult for the candidate to engage that modality if they're just so internally consumed.
Too far down to be able
Correct.
to where they can voluntarily engage in that.
Yeah, I think what is the more interesting question from a research and clinical perspective is, I wasn't surprised by this finding. This was a huge analysis. But what I think would be really interesting is you take a group of adults with depression, and there's no shortage of these types of people. You treat them initially with pharmacotherapy. You sure I'm going with this?
Yeah.
And then you randomly assign them, add the mindfulness on, or just watch them on medication. My guesstimation would be that the combined group would do better.
Then they, yeah.
That's my guess, yeah. That's my guess. ECT, and this, look, there's been lots of ketamine clinics. There's a lot of TMS clinics around town. And my TMS colleagues get a little upset. By the way, just last month, yet another publication came out saying that there's a publication bias with TMS, a significant overpublication of positives for TMS. And ECT consistently outperforms TMS in TRD. And that is an inconvenient truth for a lot of these TMS clinics. I just thought you'd want to know that. We all know ECT is not doing as well in public relations as is TMS. People want to have a beer with TMS, but not ECT. So that's a major issue, of course, access to the treatment. And finally, this is interesting. You all know that internet-based, computer-based CBT seems to be as effective as your warm, empathic psychotherapist down the street. It turns out, and this probably won't surprise you, this was a wonderful analysis done, just published in JCLIN, this is 2019 as well, that this is clinician-supported, computerized CBT. This is just go to your Google at home and do it yourself CBT. It turns out that the clinician-supported computerized CBT does better. And I don't think that surprises you. There's probably some guidance along the way. There's additional support, probably more concordance and things like that. So Dr. Google has not supplanted your friendly therapist just yet, and it looks as though that your clinician, he or she should stay with Dr. Google to help you along the way.